Right, good evening, doctors, and welcome to another one of Genoa Underwriting Managers CPD events. Genoa Underwriting Managers, as a large number of you in the room will know, is a liability-focused insurer. We focus on professionals like yourselves, and we've got very well-established books across attorney, business rescue, liquidation, fiduciary, and medical practitioners. I'd like to thank you all for taking the time to join us this evening. We will be fortunate to be addressed this evening by Dr. Brad Byra. Brad is an accomplished speaker who has spoken in venues all around the world, and we are very lucky to have him as part of the team here at Genoa Underwriting. In addition to that, I'm also pleased to introduce you to a lady by the name of Jeanette de Villiers from MC de Villiers Insurance Brokers. They are a PI specialist in the medical malpractice space, and I'm going to hand over to Jeanette, whereafter she'll just introduce her company, and then we'll hand over to Brad. So thank you. I hope you all enjoy the presentation and have a great evening. Jeanette, over to you.
Thank you very much, Michael. A very warm welcome to you all, and thank you for taking time out of your busy schedules to join us for an informative session by Dr. Brad Byra, which I'm sure you're all going to enjoy. My name is Jeanette de Villiers, and I'm here to share how I have assisted many specialists over the past 3 years in unpacking and understanding their current medical malpractice cover and ensuring them absolute peace of mind on an annualized basis. I personally started the year in 2020 with great enthusiasm, and all of a sudden everything was put on hold. So now we've had to look at the business in a different light, and it's all about offering world-class customer service, and we're absolutely committed in achieving this. I know that you've all had a very tough 5 months taking care of your patients, complying with regulation, and keeping up with all the changes in the pandemic. Fortunately, us South Africans are very resilient, and we always stand together and support each other, and we will get through this. So how can I assist you? I can assist you in currently reviewing your current medical malpractice cover and ensure that you have market-related cover and are paying the appropriate premium for this. Secondly, I can assist you in understanding what type of cover you have and your terms, your conditions, extensions, claims reporting, and renewal process. I'd briefly like to introduce you to a revolutionary medical malpractice offered by Genoa and on a claims-made basis and reinsured by the largest reinsurer, Munich Re. So what can you expect from us? Personal service and tailor-made solutions. The benefits are very compelling. They are competitive and sustainable premiums, multiple policy extensions and premium holidays, extended reporting for a period of 60 months, flexible excess options, which is very unique in the industry. You've got automatic 60 months extended reporting period. You also have access to minimum health records, informed consent templates, CPD online portal for CPD ethical and clinical points. And we've got a strategic alliance with SA Medical Specialists who can do a free plagiarism check for you, as well as a legal disclaimer on your website at a pre-negotiated price. I'm very confident with the solution, and I believe it will bring great value to you and savings and exceptional service. And now over to Dr. Brad Byra, who I'm sure you're going to enjoy the webinar with and the presentation with on medical errors. Thank you, Brad.
Thanks, Jeanette. Thanks, Michael. Hi, everyone. Greetings from a very, very frosty Cape Town. If any of you are here, you'll know it's proper wind and proper rain. And if any of you aren't here and you're up in the north, it's heading your way. So we've got something to look forward to. I'm sharing my screen now so that I can put the presentation up, and it'll behave itself in a couple of moments. Just by way of introduction as to how I like to do these presentations and collaborate with you, this is an ethics presentation on medication errors and the impact of medication errors and how to manage them. I'm not here to talk to you today about what medicines to prescribe in which way, at which dosage, and which day. And it's one of those presentations which is slightly more difficult to do because there are nuances and subtleties to it. We're not going to talk about the Pharmacy Act today or go into any components of medication preparation, but we will talk about, and this is part of some of the background that I'll share with you, we're going to talk about the World Health Organization's medication risk management strategies. And I'm going to try and link those into what could be common practice for yourselves. What's worked in the past and what I'm going to suggest we do now is you'll see that you've got a chat facility on your screen. If you've got a question that you'd like to do, just put it up onto the chat. I'll try and answer it in real time. We're going to go forward for about 50-55 minutes. And after that time, we can do some questions and answers. The purpose of today is really just to guide you through what you might or might not be considering in terms of how you manage medications, either as a prescribing or as a non-prescribing, dispensing or non-dispensing practitioner in your own right. So if there's no questions from you now, I'm going to start and then we'll move on. I don't know if all of you know what a moral hazard is, but a moral hazard generally is where your best intention leads to a bad outcome. And the first time I was exposed to the moral hazard principle was where we started working with the HIV positive and at-risk communities in the late 1990s. And at that stage, we said we would provide a lump sum benefit to any person who became HIV positive. That was just after working in occupational health and safety injury reviews, where we learned that based on, there was a tariff, a schedule of tariffs that many of you will know, that based on how much money the person needed, they decided which finger on which hand or which ear they would cut off, because that's how much money they could get. We also then found with those that we were writing insurance policies with for HIV, that people would become deliberately exposed and seroconvert so that they could get the money so that they could manage their debts. And that's the idea or the representation of a moral hazard where the best intentions go wrong. So in terms of a document that was published last year, Medication Safety in Polypharmacy, through the World Health Organizations, they state openly, and we all know this, that healthcare interventions are intended to benefit our patients. But at times they do also cause harm. And part of the reason for that, as you'll appreciate, is there's a really complex combination of processes, technologies, and our own human interactions that make the healthcare system that we work in profoundly complex. Now, in doing this presentation, I've done this presentation across SADC and in some of the more rural countries where we start looking at medication errors. And while I was in a rural area, so sitting on one of the boards that I work with, the board is called Mudiro, and they provide access to healthcare, including medication safety in northern Namibia. And so crossing over from northern Namibia into Botswana, I met with a couple of practitioners and pharmacists there, and they say, yes, we call it the paracetamol treatment. If you have a fever, you get paracetamol. If you fall off the ladder, you get paracetamol. If you have malaria, you get paracetamol. I said, well, you've got to explain this to me. They said, it's quite simple. Our formulary only has paracetamol. And so we understand that sometimes there's a limitation to the health delivery system that limits what we can do. But there is within everything we do, because we're in a complex health system, the inevitable risk that we do patient harm. And that patient harm can and often does result in actual harm. Largely, we try not to create harm because that's our mandate, but harm does happen. And because harm happens, people like me who do medical legal work have a job, and people like you stay up at night worrying about if you'll be getting a call for your records or if an outcome will happen. I remember the first time I had a patient that had an adverse outcome. I was absolutely gutted by it. But the reality is these things do happen, and when they do, we need to manage them for what they are. And that's a little bit about moral hazard as it relates to where we are. So when we look at patient safety and medication errors, in a couple of the other talks that I give, I talk about the fact that 1 in 25 patient care events results in a patient safety issue. That's 25% of people. It's a lot of people who end up potentially harmed. And adverse outcomes and adverse events now relate to the approximately the 14th leading cause of death. Now, to put that into context, that's equivalent or has an equivalency of malaria, and it has the equivalency of TB in terms of a worldwide risk. So adverse events are there and they're real. Partly what we want to try and do as we manage patient safety is to prevent harm, specifically avoidable harm. Now, when we talk about harm, I introduce a phrase, and I'm going to introduce it here, and I'd like you just to maybe carry this through as one of the messages today. You get two types of outcome. One is called an error by commission, which is something that we do, and because we've done it, because we've executed on something possibly incorrectly, sometimes maybe negligently, there's harm to the patient. There's also something called an error by omission, and that is something that happens because of something we've left out. A message that we didn't give, an instruction that we didn't share, a communication that we didn't do, or a test that we may have done but didn't. And so as we go through this, I'd like you to potentially reflect on your own practices under what we call the ESLI, the ethical, social, and legal implications of the clinical practice that we provide to our patients. So as we go forward, the global patient safety challenges include one challenge specifically, and that's a little bit about what we're going to talk about today, which is medication without harm. This is published in the Medication Safety in High-Risk Situations by the WHO as of late last year. Of course, we know that since last year, the world has significantly changed. I can tell you profoundly that my levels of ambient stress, clinical stress, and environmental stress have increased, especially as we're starting to see infection and death rates increase in terms of COVID. So this is medication without harm. And medication without harm has four specific legs to it. The leg that affects the patient and the public at large, because often when we create an outcome that's an undesirable or a poor outcome, it relates to patient engagement, it relates to reporting and self-reporting by patients and sometimes patient advocacy groups, but it also affects the public at large because it affects the families and it affects friends, and sometimes it affects employment and employees. So that's the wheel, or the component of the wheel, that relates to the impact of our medication regimes to patients and their families. It also affects us as healthcare professionals in terms of the education and training, in terms of an area that we are less good at called communication and teamwork. And I don't know if any of you have read books by a general surgeon called Atul Gawande. So Atul Gawande wrote a book called The Checklist Manifesto, where he was asked to go into low and medium income countries and understand specifically why there were poor surgical outcomes in certain circumstances. And basically what he came back with was, we sometimes leave out things. And without a checklist where we can tick off some specific action items, and today I'm going to share with you one or two checklists as they relate to prescribing and medication care. But if you don't have a checklist and you don't communicate well with your colleagues and with your patients, the likelihood of things going wrong is significant. And so with that, he wrote the first book, Checklist Manifesto. He then wrote a second book called Better, where he still propounded the importance of communication and capacity and incident reporting and learning. Then he wrote a third book, and the third book he called Complications, where he said, despite us knowing what we know, we still get it wrong significantly and more than we should. And the previous slide gives you a sense on how often we do get it wrong. So the third piece of the wheel on medication without harm is actually how we manage the medicines. The 5 rights we're going to talk about, the right product at point of care. Storage and disposal and logistics plays a role, but so does naming and labeling and packaging. Product quality and safety is somewhat outside of our control. I was the risk manager of a specialty orthopedic hospital for a while, and the management of medicines and the similar naming medicines and the similar dosage medicines and the use of a 0 in front of an apostrophe on the dosing made a big difference. And that then goes into the fourth part of the wheel, which is the systems and practices of medication, how we govern it, what our prescribing, preparation, and dispensing behaviors are like, what our administration and patient monitoring is like, and what our monitoring and evaluation is like. So this should give you a sense that when we talk about medication and medication errors, or providing medication care in our practices, there is a much broader structure that I don't think we often are aware of. Within that structure, we're going to talk about three things. One is the polypharmacy, the other is high-risk situations, and the third are the transitions of care that can put both yourself as a practitioner and your patient and the ecosystem in which you work in some degree of stress. So I hope I'm making a little bit of sense here as we go on. I always find with these talks that without being able to see people, it's always difficult to know whether I'm making sense. I hope I am, but whether it's resonating with you. So pharmacovigilance, when we talk about it, is there to improve patient care and safety, specifically in relation to the use of medicines and medical and paramedical interventions that relate to the use of medicine. It's also there looking at public health and safety and improving public health and safety in the use of medicines and the choice of medicines. It's also used to detect problems relating to the use of medicines and to communicate these in a timely manner. Now, when we talk about this, in terms of detecting problems, there are some studies that have been done recently where the use of specific medicines, which are used to combat the side effects of other treatment regimes, are being used as a way of understanding whether the first-line treatment efficacy is good. So we're at that ability now to measure second or third generation prescribing and dispensing and consumption of medicines as a mechanism of understanding whether our diagnostic rationale and our first-line interventions were good. And then that helps us encourage and understand safe, rational, and more effective practice of medicines and improve our education and clinical training. And so pharmacovigilance sits in a much broader world than our practices, but our practices directly and indirectly contribute to the mechanisms of how we work in that pharmacovigilance space. There are, and what I've tried to do here is reduce our conversation into a series of manageable slides and tasks. So there are 10 key elements of medication use that you might want to be mindful of. I've tried to link them where possible to the various different Health Professions Council ethical guideline books. So the first thing about medication use, and we're going to talk about this a lot through the rest of the presentation, is the importance of patient information. And that includes the confidentiality of what we do with the patient, the disclosures that the patient gives us and that we require, but also the disclosures that we need to give the patient in terms of their risks, their exposures, and potential outcomes. And then the patient records and the record keeping that relates to booklet 9. The second thing that's important to be aware of is the drug information itself. And here, when you start looking at the protecting and providing of information, you need to be aware of booklet 5. Obviously, you need to be aware of all of the booklets, but I'm highlighting those that are specific to this. The third, and possibly for me, it's highlighted in bold because it is the key element in safe medication use is what they call SBAR, which is adequate communication. Know your situation, know the background, know the assessment, and know your recommendations and record them so that they can be communicated not only in your records, but to the patient in a manner that they understand, and also to broader members of the care team as and when required. Then there's the drug packaging and the drug device acquisition, use, and monitoring. Then there are the environmental factors around the medication use. And there I'm referring you to booklets 1 and 2, which are your ethical requirements in terms of being a healthcare practitioner duly registered within the South African context. There's staff education and competency assessment that needs to be done, not only for yourself, but also for members of your direct and indirect clinical and administrative staff, nursing staff, extended staff. If you're in a hospital, also your broader support staff. But then also patient education, and we're going to talk quite a lot about this, is the importance of informed consent, because you cannot get consent or the agreement from a patient to move on to a regime if you haven't educated them sufficiently about what the use, the risks, the naming, the indications and the contraindications of that medicine or medication regime might be. Equally, and then finally, is the issue of adding quality process and risk management. to your 10 elements of medication use. So what I would ask you at this point is to reflect on your practice and say, in your practice of patient management, which may or may not include prescribing, or it may or may not include dispensing, how many of these 10 items can you tick to say that you're scoring yourself a 7+ out of 10 for comfort, for thoroughness, for accuracy? So I apologize now, because a lot of what I'm going to be asking you, you may find that there are gaps in your record keeping or gaps in your communication. But this also then gives you the opportunity to start providing additional robustness to your practice. So I was startled by this when I started doing the SADC work, and we did this talk in 7 different SADC regions, and I asked everyone the same question that I'm asking you now. If you didn't see this, and I arrived and I called you up and I said, what are the 5 rights of medication administration? Would you be able to say the medicine needs to go to the right patient, the right medicine, in the right dose, with the right route, at the right time? Now, that's complex enough in a hospital environment. But if you've got a patient who you have seen in either an OPD, an outpatient department, or you've seen in a ward, or you've seen in your rooms, or you have done a procedure with, and you've now recommended that they have a particular medication regime, are you following it in the right way? And do you keep a medication administration record? Do you keep one for your practice? Do you know what you prescribe, in what doses, with what frequency, to what type of patient? And are you able to compare that to the compliance that you have that is self-reported and measured by yourself in terms of your post-discharge or post-treatment recommendations with your patients? So those of you that would like this, you're welcome to connect and get this presentation afterwards and go through this checklist for yourselves. In terms of, we go back to medication without harm, there are some significant areas. These are some of them. In a lot of the countries and outside of where we are here, unless you're potentially working in non-profit organizations, non-profit companies, or facilities where medicines are donated, there is a risk of substandard and counterfeit medicines. There is also the risk of expired medicines. There's the risk of donated medicines. There's the risk of interactivity between medicinal preparations, and we'll talk about that a little bit later. There's the informal distribution, where your scripting is getting sold out of somebody's handbag or shared amongst people. I've often found in certain circumstances, I say to somebody, well, you're suffering from headaches? And they said, oh, not to worry. I've got a friend who, every time I've got a headache, she just reaches in her purse and gives me a light cream pill. I say, well, what is it? They say, well, I don't know, but it works. And there's an informal distribution channel that could also lead to the 2 that I've bolded for us to be mindful of tonight, which is your incorrect use of medicines and polypharmacy. And that's where I'd like to take us on the journey of where we are now, is just to go into polypharmacy and incorrect use of medicines. I'd then like us to walk through 2 specific items in terms of how to manage medications, and some recommendations that came out of a series of studies, both in the US and the European Union, on reducing your litigation risk and improving the patient safety risk. And then finally wrapped it up with some of the comments around what we are required to do in our clinical practices here in South Africa. So conventionally, polypharmacy has been perceived as an overuse of medicines, but it may be better to look at polypharmacy in terms of the appropriateness of the medicines used with each other, because there are cases where multiple concurrent uses of medicines are necessary and beneficial, but not always. So polypharmacy, by its definition, and will probably come up later as we go through this presentation, is where there are 4 or more medicines being taken by a patient, where those medicines are possibly going to have the potential of interacting and creating concomitant outcomes. So to what extent should we involve other professionals in the patient's care? I've put that out there because when I first got exposed to this, I was working through University of California, Berkeley School of Public Health, and they were running a program global health efficacy, and they were using a health system called Kaiser Permanente to reflect the successes of interdisciplinary, integrated, highly communicative care that was patient-centric. And their chairperson at the time wrote a book called From Chaos to Care. And the statements that he made at that point, his father was elderly at the time, in late 70s and into his 80s. And he was stunned, shocked, and or saddened by the fact that the different specialists didn't necessarily know what his father had been prescribed, and inadvertently off the back of that was creating certain iatrogenic and idiopathic complications caused by those medicines. So if you're concerned with the metabolic side effects, should you share what you're prescribing with the patient's primary or secondary care practitioners who are managing their blood pressure and cholesterol? If you're putting the patient onto a diuretic, could that be diabeticogenic? And if so, do you need to find out if that person is being managed for their diabetes by somebody who's other than you? And do you need to communicate with them? Now, we go into those ESLIs again, the ethical, social, and legal implications. Would you be accountable? Would you be liable? Would you be considered negligent if you were prescribing something that may have an amplifying effect of a different medication that could lead to a worsening or poor outcome as a consequence? Well, certainly. So to what extent should we be involved with other professionals? Well, that's your discretion. My position is the more we communicate, the more effectively we communicate, and the more effectively we share key records, the less likely we are to have a patient who falls through the cracks of our care. This is an example that came out, and I thought it was relevant. And it's relevant because later on you're going to see a tongue-in-cheek but fairly serious position of the medical alphabet. And when I first started seeing patients, which was back not so long ago, it was 1994, 95, 96, I had a pharmacist come with a list of typed out meds, and they said, just write next to each medicine. Write it out in freehand. And I said, well, why? And they said, well, because I'm not necessarily going to recognize your handwriting. So I'm just going to hold it up to this template and off that get kind of a sense of what you're looking for. And so this is a tragic example of a child who dies because of the misinterpretation based on the handwriting that leads to the wrong medicine, that leads to the wrong outcome, that leads to steroid-induced diabetes and diabetic ketoacidosis. So medical errors like this not only can happen in a healthcare setting, they do happen in a healthcare setting to the tune of several 100,000 globally a year. So I raise that for you to be mindful of the correct use of medicine. Now, one of the challenges we have is the use of too many medicines per patient. That's the polypharmacy that we've spoken about. And at this point, I would ask you from a point of self-reflection, do you know emphatically what your patients are taking, not only what you're prescribing, but what they may be taking without realizing, and maybe you haven't asked? Also, the use of inadequate dosage and inadequate use of or inappropriate use of antimicrobials or similar for non-bacterial infections. The use of, well, I worked in an environment where they gave vancomycin as the first line antibiotic. So, well, if vancomycin is the first line, what's next? And so we have to bear in mind that that is a situation. And we see it now. We've got drug-resistant tuberculosis, and we've got multiple drug-resistant tuberculosis, and we've got extremely drug-resistant tuberculosis. And these are all as a result of often, but not always, inadequate dose or inappropriate use. The overuse of injections when oral formulations could be more appropriate. Failure to prescribe in accordance with clinical guidelines. Now, that's a challenge, because the questions that you would need to be able to answer for yourself is, do you have the clinical guidelines? And are you prescribing in accordance with them based on your discipline and your specialty? Then the inappropriate self-medication, not that any of us do it. Not that any of us know any patients that do it, but if we did, and you did know that somebody was inappropriately self-medicating, what would you do about it? When you reboard a script, are you re-examining the patient sufficiently? Or are you doing it telephonically, or are you doing it using the new telehealth provisions? How carefully are you monitoring the self-medication or prescription medication consumption? And then there's, of course, the interaction between contemporary allopathic and alternative medicines, to use loosely used terms. And an example of that is the one that you've got below. But one of the examples that happened quite early in, or late 90s and early 2000s, was the use of arnica became very popular. But as you know, arnica relates and can precipitate bleeding. So now you've got a patient who is on Disprin or on an anticoagulant, and they're taking large doses of arnica, and you end up in situations which are less desirable than they might be. So we then go on a little bit further and we say high-risk situations you need to be mindful of. You'll recall that we spoke about in terms of medication without harm, 3 key things. The first was polypharmacy. The second was the inappropriate use of medicines. And the third is recognizing high-risk situations. And they can result in unsafe medication practices, and they can result in medication errors. Now, we're not going to talk about look-alike, sound-alike, or dosage-related risks, but we are going to talk about the use of high alert medicines, those with a low therapeutic index with a very high maximally tolerated dose. So when you look at the medications that you're prescribing, do they fall into the high risk and high alert medication categories? The second is either over-prescribing or under-prescribing or misprescribing of meds. And again, I'm not suggesting that any of us do this or any of you do this, but I am suggesting that it is something to be sentient about and start to ask the questions of. And then the third thing are the system factors: your work environment, your consulting environment, the setting in which you provide care. Nowadays, with telehealth, with patient loads, with not being able to necessarily see the patient in the rooms as you'd like to, and those are the high-risk situations within those, not to mention perioperative and neonatal care settings, which we set aside. Your system factor, plus the communication between yourself and your patient, plus your choice of medicine, or the choice of medicine that you wish to prescribe, can inadvertently create for you a high-risk situation. And a point of reflection here, you might want to ask yourself the question: how often am I finding myself in a position where I may be in a high-risk situation? You may run a very conservative practice. You may maintain significantly low risk across your prescribing habits, but you may not. So I share this with you just as a point of interest. The third piece that I wanted to share with you, outside of the moral hazards and then the issues of medication without harm, are what are called transitions of care. Now, you'll know transitions of care, but maybe not in this particular term. So transitions of care take a long-term commitment, and they take a long-term commitment because the patient needs to be cohesively supported by all of the healthcare practitioners who look after them. So all the primary, secondary, and tertiary health professionals who are involved in the treatment of that patient, plus any institutions that they may be in short or longer term involvement with. You need to be mindful of that, whether they've been admitted for a short-term stay, whether they've been admitted for a procedure and then discharged, whether they've been admitted to 2 different procedures, one being a day clinic and the other being a hospital in near horizons of time. So in order to manage these transitions of care, the ideal would be a formal structured process to reconcile the medicines at the transition points of care. And I'll give you an example before we go in and break this down. One of the groups I worked with, the nurse came to me one day and she said, well, we're really worried because we're discharging this patient who's had this procedure, and we've given them a bag of Clexane injections. And we've given them an instruction on how to use these injections. And what are our liabilities? My answer to that was, well, how do you know that the patient is going to regularly use them in the manner that they're supposed to be used? Because as the patient starts to either feel worse or better, they may not want to self-inject. They may not want to self-administer. And then the consequences of there being a clot at the op site and a secondary pulmonary embolus or worse starts to escalate. So I'm just going to answer this question if I can pull it off the screen. So the question that's raised, and this is how I like to answer these questions so that they close some time. My problem is the usually elderly patient coming for a surgical procedure with a shopping bag full of medicines they're taking for various ailments. Often these meds are not even prescribed by the same doctor. I don't know the indications, effects, or side effects of the drugs that are used outside my discipline, or how they may interact with the medicines I prescribe. How do we solve this problem? Well, I think this is a problem that all practitioners face at some stage, especially if you're working with the elderly. And so the answer to that is to catalog all of that. Nowadays, we've got great access to technology and access and unfettered access to formularies, to various drug sites, and to pharmacists. The best thing is to be able to, if you're admitting this patient, go to the hospital pharmacy and say, listen, I've got all of these meds in all of these doses, and I'm concerned because I'm about to do X procedure, and it's going to have the following implications of Y and Z. And let them give you an indication whether the polypharmacy that you got, that bag of tricks that that patient comes with, that bag of medicines, can significantly compromise their outcome. And even with your best therapeutic efforts, there could be an adverse outcome. So how do you do this? There's a health and safety strategy called Stop, Think, Act. So you get that big bag of meds. So now you stop. You now go and you need somebody to interpret them for you in their specialty, and that's the pharmacist. And that's the think. And then based on that, the act is to then say, are there other prescribing practitioners who I need to contact before I do the intervention that I'm going to be doing with this patient? Because by and large with those patients, you're not providing critical acute care. There tends to be some runway between you seeing them and the intervention that they need to have. And I suppose that comes into what they call the BPMH strategy, which is the best possible medication history. And as you build your best possible medication history, you're going to at least get the information from that patient, plus from the other prescribing doctors. And you may be able to call the rooms and get that information. You may then need to reconcile and update that medication list. And some of these medicines are probably or possibly medicines that they've brought along that they should have finished taking, but they simply weren't compliant with. And you need to set those aside. And some of them they might be taking in the incorrect dosage or at the incorrect time. And then the third piece of that, once you've got your medication history and you've reconciled that list, you then need to communicate not only with the patient, but also the other healthcare providers about the changes in medicine that you might be affecting. The question is, how much detail of the side effects do you give to the patient on polypharmacy, such as the risk of cardiac arrhythmia that could result in the death of the patient? Well, this goes into your issue on informed consent. The Health Profession Council says that if there is a 1% chance of an adverse outcome or a complication that can lead to a poor outcome, you need to inform the patient of this. You can't by omission. Remember we spoke earlier in this talk about the error by omission. You can't choose not to tell the patient of a risk that could materialize, because if that complication or the contraindication does come to bear, you could be held accountable for your non-disclosure. So err on the side of oversharing versus undersharing. Now, there's a way to overshare. You don't have to overshare in a way that terrifies the patient, but you may need to say to them, look, we've got you on this basket of medicines. You've got 6 medicines here. These 3 are for this, these 2 are for this, and this one is this. When we put the cocktail together, if you take them at the wrong time, it could lead to these feelings or these outcomes. I think it's really important that we take enough time to be able to do that with our patients. And one of the errors by omission that we often find is that we don't spend enough time talking to them about it. And off a report called the College Psychiatry Report, there are 3 recommended steps for safer prescribing that were brought out. And the first is to develop and document the clear rationale of why you want to use a medicine or combination of medicines, given the risks that they may present, because any medication or combination of medications can present a risk. If you put as an example, you put a middle-aged person who has moderately high cholesterol onto a statin, you need to recognize that there will be side effects of that statin in the dosage that you're giving that may cause muscular pain, or may cause a loss of libido, or may cause irritability, or may cause other symptoms that are undesirable to that patient, because they still ultimately have the choice as to whether they want to do the treatment or not. So here I'm referring you to the informed consent, patient disclosure, and record keeping booklets. You'll see the HPCSA booklets that are there. You can download the entire set of booklets. It's 334 odd pages. But your first step would be to develop the clear rationale and record the risks and benefits of your reasoning on your record. I'm choosing this medicine in this way because of the following. You then need to engage with your patient on this so that you can get their informed consent about what you're recommending, and they can have alternative choices. You cannot force the patient to take the medicines because it's not your choice to adopt the treatment, it's theirs. Except in extreme circumstances where there's a significant impairment of decision-making and reasoning, or there are other emergency situations. We're not really talking about that today. But once you've developed your rationale, you've got to get your patient engaged in that through the informed consent discussion, and then record that consent. And then the piece that I think we don't do as well as we might, I'm saying I think because I don't know your practices, is monitoring the patient closely enough to understand whether there are problematic side effects. And in order to do that, you've got to follow up with that patient after they've left your rooms, possibly the next day, possibly the next week, or possibly at significant periods of time. And it might not be you following up. You may have a practice administrator follow up. You may have a nurse follow up. You may need to know that there's a requirement to lower the dosage. You may need to stop the medicine. You may see that there's problematic side effects that will fade if you continue use. So the question that I would ask you at this point in self-reflection is, as you prescribe your medicines for your patients, do you have a clear rationale of what you're describing, and is it written down? Have you shared this with the patient in a way they understand, and have they consented to it? And are you monitoring them post-prescription to make sure that what you're doing is resonating and is safe and is getting the therapeutic outcomes that you want? So World Health Organization calls this the 5 moments of medication safety. And they go through by saying the first moment of the safety is starting the medication. Now, in order to start the medication, the patient needs to go through those steps of understanding what medicine they need to take and when and why. They also need to understand that if they take it in the wrong order, which is the second moment of medication safety, that it may lead to outcomes that are not the intended outcomes, or may lead to adverse outcomes. And how would they know that it's not the intended outcome? What might they feel? What might they experience? Then, if you're going to be adding additional medicines, or another practitioner is going to be adding additional medicines, how do we walk that journey? So now you've started me on a medicine. I'm your patient, and you've explained to me what needs to be done, and I'm now taking my medicine. How do we know I'm taking it? How do we know I'm taking it in a compliant manner, and that I'm self-medicating in excess, and or I'm not medicating my colleagues, and or I'm not selling the medicine on the market? Then when I go and see, I might go see a different practitioner and forget to tell them about the medicines I'm taking from you, because I've gone to see them for my diabetes, and I've come to see you for my high blood pressure. And because the hypertension and the diabetes are seemingly different in my mind, I forget to mention the one to the other. Or because I've been taking a whole lot of preparations that I'm buying as OTC, so I'm taking, for example, Fexor 180, and I'm taking 2 a day. But I don't think about that as medicine, because that's an antihistamine, right? And I'm buying that over the counter, and that's really just for every now and then my cat allergies. So now I'm taking that for my cat allergies, but I don't tell you about that because it's not a medicine in my mind. So being able to unpack what medicines are being added requires a thorough review of my meds by you. And you need to be able to have a checklist that you're going through that says, what medicines are you on? What's your list? Are you adherent to these medicines? How long have you been on them? And then ultimately, everything that starts should stop. So stopping my medicine, titrating my doses. And we saw this often in one of the periods of work that I did, where you have elderly persons who get admitted into long-term residential homes. And the children who've been caring for them or others who've been looking after them forget to tell you that they've been on some form of benzodiazepine. And so now these unfortunate individuals start to go through withdrawal symptoms, or they're manifesting an overdosing of their benzos, and they need to be titrated off these medicines. So starting a medicine and stopping a medicine requires a therapeutic structure to it that affords both yourself and your patient the right degree of control to ensure that the outcomes are not adverse or that the medication doesn't lead to harm. I hope this is making sense to you. I see no questions, so I'll just, as I say that, the question came through, so thanks for that. Many drugs don't have sufficient testing in children, but are nevertheless a useful drug and are so used off-label. Absolutely correct. Now, if you're doing that, you need to be aware that the consent for a child to take the medicine needs to come from the parent, and it needs to be a written consent. So you need to disclose to the parent, this is a useful drug. This drug is used in the following way in its traditional usage. This is its off-label use. I believe it's correct, and here's my therapeutic and diagnostic rationale. And off the back of that, you then need to be able to justify when you use it that they understand. They understand that it's used in the following way. They understand what its side effects, indications, and contraindications might be. So it's not about whether you can or can't use the drug. It's about how you communicate the use of that drug so that your patient and their family, or the patient and their guardian, or the patient and their parent, or the patient in their own rights understands what it is that you're doing with them. So I just want to change gears slightly here, and we'll come back to some of these questions. In terms of issuing prescriptions from a medication management point of view, specifically with reference to Booklet 9, Section 7, and referencing Rule 17 of the guidelines, you as a practitioner can use typewritten, computer-generated, or pre-typed, pre-printed, standardized prescriptions for Schedules 1, 2, 3, and 4 medicines. When you are issuing medicines scheduled in Schedules 5 and up to Schedule 8, you need to have them done. They are required that they're done in a handwritten form or using your personal and original signature. So the challenge with that comes in, and I'm going to leave this up for a moment, because as you write these, you need to state, there used to be a Merck manual that you could have on your desk, and a MIMS, and you would have your MIMS and your Merck manual, and both of them were printed on onion skin paper with thumb indentations, and you could open up and you could look at the dosages and you could do calculations. You can get the equivalent kind of resources that are on your handset and that are on your tablet and on the laptop. So bear in mind that the mechanisms of issuing your prescriptions needs to still comply with those requirements from the Health Professions Council. And I move slides off the issuing handwritten prescription slide to the next slide, which suggests that legible prescriptions and records are important. I use this, and I usually title this slide the medical alphabet. And I joke to say, how did anyone get into medical school? And the answer was, well, you handwrote your application, and if they could read it, they threw it out. If they couldn't read it, you were welcome to come in. We have, as a profession, not only locally but worldwide, the most terrible hand script. And it's not only in the alphabet A to Z, It's also in the numbers 0 to 9. And when we talk about legible prescriptions and legible patient records, one needs to be aware that the illegibility is what often trips us up and gets us into tremendous trouble, because either the pharmacist can't read your writing or you can't read your writing after the fact. And if there's a dispute or if there's a challenge, the pressure on being able to justify and support what you've done comes back to your records. In a court case from 1924, the statement that was made by the judge at the time was, what you record is as important as what you do. So notwithstanding all of the other components that we've spoken about earlier, I would strongly suggest that if you are writing scripts and these prescriptions are leaving your office, if you're writing them just for the fun of it, that's one thing. When things leave your office, they need to be legible and reliably so. So, tongue-in-cheek it is, patient records need to be kept. This is booklet 9, section 4, and it specifically references rule 17 in booklet 1. You need to enter and maintain at least the following information about every patient. In 4.1.5, the proposed clinical management of that patient needs to be in the record. This is notwithstanding that you have to put the patient's details in, the time, place, and mechanisms of your consultation. You also need to go into the history of that patient, then the clinical management. You also need to include in your records the medication and dosage prescribed and the patient's reaction to that medicine and treatment or treatment, including the adverse effects. You also need to include test results. Now, I say this because I'm not sure always that we take the time when we write our clinical notes to accurately record the medicine and the dosage, plus a follow-up of the patient's reaction to that medicine 1, 2, or 7 days post-event. So it's a point of reflection for you, especially if you are treating patients where there are more than one medicines or there are more than one comorbidity. So the question here is, what about pharmacies that sell scheduled medications like antibiotics directly to patients? I often get patients that have been given inappropriate medication. Well, absolutely, that's a risk. Now, what needs to happen there is you need to be able to firstly catch that with the patient, and secondly, follow that up with the pharmacy, because there's a broken telephone journey that happens here. So how did the patient get the inappropriate medicine? What did they say their symptoms were when they presented to the pharmacy to get the medicines that they were asking for? Did they present with the same clinical presentation, the same clinical manifestations, the same symptoms and signs, or were they saying something to get a particular kind of medicine? There is something on the medical legal side called contributory negligence, where whilst we regard the patient as being honest and authentic and willingly trying to give us all the information, there are times that either the patient deliberately or inadvertently misrepresents their circumstance. So let's understand that sometimes when a patient presents with a basket full or a handful or a packet full of medicines, they may or may not have been fully transparent with the previous persons or practitioners or pharmacists they got the medicines from. So we need to be mindful of that. So as we wrap up this presentation and we come out of the hour and open up for questions, the last 2 slides, the first is document everything. That includes proper medication labeling. It includes, as we've just spoken about, legible documentation. It includes the proper recording of administered medicine, because any lack of proper documentation for any medication can result in an error, and it can also be perceived to be negligent. So reading the prescription label and expiration of the medicine is also a good best practice. And sometimes when a patient comes in and brings their meds, having an understanding that you've got the right medicine in the right bottle with the right expiration date and it hasn't expired is an important journey. So sadly, we also know, and because to err is human, and there's actually a medical area book called To Err is Human, that correct medicine can have the correct label, but it can also have the incorrect label. and the correct label can have the incorrect medicine. So we can get into medication errors despite our best efforts to be diligent. So this is a very useful tool that I want to share with you. It comes off the site. You can see it there, minoritynurse.com, but I like the 10-step strategy. The first is ensure the 5 rights of medication administration. We did them earlier on, and if I was to press you now, would you be able to list those 5 rights? Do you have proper medication reconciliation procedures in your practice? Do you double and triple check those procedures to ensure that they're good? Do you have somebody else sometimes read it back if you're in an environment where you are instructing a different person to provide the mode or mechanism of providing that medicine? Do you use name alerts? One of my scaries, and I've lived this and had significant adverse outcome results for people under my care, where a practitioner was phoning in to give the nurse the dosage. But what the practitioner said of 10 and what the nurse heard was of 100 had a significant dosage difference. So if there's a decimal point, have you put a 0 in front of that decimal point? Are your numbers legible? Have you documented everything? Is it clear? Are you managing and storing medicines in a proper way? And are your patients who you're prescribing to managing and storing medicines in a proper way? If you're working in an institution, are there medication administration policies, regulations, and guidelines? If you're dispensing, do you have medication administration policies, regulations, and guidelines? And then one thing that we've spoken about a few times through this is consider having a drug guide available at all times through your journey. So I've put this up very quickly to say, in the medication errors risk universe, you need to understand high-risk situations, polypharmacy, and transitions of care are your early areas and priorities to be able to manage risk. You need to understand that inpatients, young children, and the elderly are at high risk. Young children because they can't always tell you, and the elderly for exactly the same reason. There is always the administration of wrong dose risk, or the use of the wrong route, or either a colleague or the patient not following the treatment regime. 4 or 5 or more medicines, including over-the-counter and prescriptions medicines, is regarded as polypharmacy, and as a consequence, there's an increased risk of side effects, there's an increased risk of drug interaction, there's an increased risk of adherence and compliance. Your transitions of care as patients move between families, facilities, sectors, or healthcare practitioners. Now, I say families because sometimes an elderly person goes from one family member to another. Equally, through this, there's the risk of communication errors in the transitions of care. So managing that through not only prescribing, but also making sure that what's transcribed and dispensed is correct, and that monitoring and administering those doses for patient follow-ups is important. Equally, you want to make sure that we understand that human error, fatigue, and adverse drug reactions are often the causes of medication errors. We recognize, and we've spoken about the 5 moments of care, from introducing a medicine to a patient to ending that, and how we develop the functional status of understanding and the patient's understanding, how we encourage adherence and how we empower their work, and then how we work with our patients and the public, how we understand medications, how we behave as healthcare professionals, and how we integrate the system are ultimately the components that make for a medication without harm strategy. So at this point, I want to thank you all very much. We've gone through an hour. I'm going to answer this question and then hand back. If you work in an OR environment, how do we encourage people to report medication errors? It's a lot more complex in an OR environment. One of the things that you would have there is you would have various different reporting opportunities through the hospital risk management systems, through the sentinel event systems. Best way that I've found is to encourage no fault reporting. And that's always difficult because the nurses don't want to report against the doctors, the surgeons don't want to report against the anesthesiologists. I walked into an OR environment once where the medications book that the anesthesiologist was supposed to be signing, there were pieces missing. And when I say to the nurse on duty, and I say to some of the people, what's going on here? They say, yes, but we didn't want to really upset the guy. It's a nice enough person. So you've got to be able to create a safe, sometimes anonymous reporting structure. It depends very much on the environment that you work in. So with that as a closure and opening up for discussion, I'd like to hand back to Michael and Jeanette.
Thank you, Brad, for a most informative talk as always. I'm sure I speak for a lot of the doctors and practitioners in attendance in thanking you for putting it together. Doctors, this now is your opportunity to raise additional questions with Dr. Byra on the talk that has just happened. In order to demute yourself, if you are in front of a laptop or a computer, all you do is simply hold down your space bar, and that will allow you to speak. There are a number of people in the room, so if more than one person is speaking at the same time, please just obviously be courteous. For those of you who are signing in via iPhone or Android devices, I'm not entirely sure how you'll demute yourself, so it would probably be best to use the chat function to raise any questions, and then Dr. Byra can raise those. So I'm going to hand over to the floor, wait a couple minutes to see whether we hear from anyone. If we don't, then we will be signing off the evening, and we thank you for your attendance. Over to the floor.
Looks like I get a free pass in Q&A.
I think you did. Someone, Gregory Weir, has asked rules regarding printed scripts.
Yeah, so thanks for that. The answer to that is printed scripts can be used for, as you saw on one of the previous slides, for scripting medicines, schedules 1 to 4. Currently, the HPCSA's guidelines, which haven't been amended to the best of my knowledge since the beginning of this year, say that scripting for schedules 5 and above need to be handwritten. If that does change, I'll share that with you.
Perfect. Doctors, just while everyone else just works out how the spacebar and the different ways that we can interact on the platform work, with regards to your CPD certificates for this event, they will be passed along to the ever-capable Jeanette de Villiers, who addressed us all a little bit earlier, and she'll ensure that they are delivered to all of you.
So there was a question that came through. Will informed consent apply to vaccines? Absolutely. Informed consent applies to any aspect of any care and any medicine you give to any patient at any time. And if you're vaccinating the child, you need informed consent from the parents.
All right, I reckon we give it another 20, 30 seconds. See whether anyone's got any last questions. Otherwise, I'll be signing off.
Michael, can I just raise something?
Sure, go ahead.
This is Howard Radford speaking. I'm an anesthesiologist.
Hi there.
And one of the issues, obviously, is safety and medication in the theatre complexes that we work. When I first started training, we had a very simple set routine of how we were going to label our drugs, etc. But over the years, this system has been changed, it's been subverted, so that there's now no uniform system currently. And I think that obviously from a safety perspective and to prevent the administration of the wrong drug or the wrong dose, we need to go back to these basics, not only necessarily in anesthesia, but in all other types of medications as well. I mean, we've seen labelings on 2 solutions that they will both be in red and both in a 50 ml bag, and they get put into a trolley, and so it's very easy to grab one in the heat of the moment and give the wrong agent without really checking, but just because of the writing and the shape, you tend to do it. So I think the big challenge is to get the world to develop a uniform labeling system of medications that's accepted throughout the world, not just in one little area or one country.
Yeah, Howard, you're absolutely correct. And as we've become a broader community, our systems have become much more complex and unyielding. You'll recall when insulin and saline, one was navy blue and the other was black, and if you put them in a cupboard that had a fluorescent light, they looked the same. So these are perennial challenges that we're having. And as the hospital groups compete with each other, they tend to set up their own guidelines. So in the perfect world, you're absolutely right. It would be wonderful. And from SAS's perspective, just to use your discipline, I know that there's a tremendous drive to create standardized guidelines and uniformity in how that works. But we see that in managing omnicells and stocking the omnicell and the route of delivery so often causes the adverse outcomes. So thank you for your comments, very valuable. And back to you.
All right. I think that probably, unless anyone has got anything further, I think that probably wraps up the evening. Jeanette, have you got any parting words for the practitioners?
I'm trying to unmute. Thank you very, very much for the opportunity of introducing MC de Villiers Brokers. I look forward to giving you all your certificates, and I will be engaging with you personally on any of your requirements. Thank you very much, Michael and Dr. Byron. Much appreciated.
All right, everyone. On that note then, stay safe and enjoy the rest of your evening. We hope you enjoyed the session, and we look forward to seeing you at future ones. Cheers, everyone.
Bye now.
Bye. Bye. Thank you.